Welcome to M.D.Zafar lectures. I am Dr. Danish and I will be giving a lecture on orbit. If you are new to my YouTube channel, kindly subscribe so that you can have notification whenever a new video is uploaded. In this lecture, our aims and objectives would be to understand the anatomical structure of the orbit, which includes its openings, borders, and relationships, to understand the related physiological functions, though which are very few, but you need to know them, and understand clinical problems associated with the orbit and their respective managements. Now, talking about the anatomy. Anatomical structure of the orbit, we have to discuss its borders, its anatomical relations, the contents of the orbit, and the pathways of the orbit. Now, first of all, we'll talk about the borders and the anatomical relationships. The roof, which is the superior wall, is formed by the frontal bone and the lesser wing of sphenoid. This frontal bone separates the orbit from the anterior cranial fossa. This is the frontal bone. Now further talking about the floor, which is the inferior wall, it is formed by maxilla, palatine, and zygomatic bones. Now the maxilla separates the orbit from the underlying maxillary sinus. The medial wall is formed by four bones, namely ethmoid, maxilla, lacrimal, and sphenoid bone. Ethmoid bone separates the orbit from the ethmoid sinus. Talking about the lateral wall, it is formed by the zygomatic bone and the greater wing of sphenoid. Now we know that the lesser wing of sphenoid is making the superior wall and the greater wing of sphenoid is making the lateral wall of the orbit. Talking about the apex, apex is formed by the opening of the optic canal, and the base opens into the face, is bounded by the eyelids, and it is known as the orbital rim. Now further talking about the contents which are present within the orbit, and they include extraocular muscles. These muscles are separate from the eye. They are responsible for the movement of the eyeball and the superior eyelid, and they include levator palpebrae superioris muscle, the two obliques, superior and inferior, and four recti, superior, inferior, medial, and lateral. Talking about further contents, it has eyelids which cover the orbits anteriorly. Nerves. There are various nerves which are present within the orbit, or it passes through the orbit, and they include the optic nerve, the oculomotor nerve, the trochlear and trigeminal, and abducens nerve. Now talking about the blood vessels. The eye receives blood primarily from the ophthalmic artery, and the venous drainage is by the superior and inferior ophthalmic veins. Any space within the orbit that is not filled by anything else is filled by the orbital fat. Now this tissue cushions the eye and stabilizes the extraocular muscles when their movement is required. Now we will talk about the pathways in the orbit. They are important from MCQ point of view. For example, somebody can ask you what are the structures which passes through the optic canal, and the answer would be optic nerve and ophthalmic artery. Similarly, superior orbital fissure transmits lacrimal, frontal, trochlear, that is the fourth cranial nerve, oculomotor, the third cranial nerve, nasociliary, and abducen, which is the sixth cranial nerve. It also carries superior ophthalmic vein. But the things which you need to remember are the three nerves: trochlear, oculomotor, and abducens nerve. Inferior orbital fissure transmits zygomatic branch of the maxillary nerve, the inferior ophthalmic vein, and the sympathetic nerves. There are other minor openings which are also present in the orbital cavity. They include the nasolacrimal canal. It drains tears from the eye to the nasal cavity, and it is located on the medial wall of the orbit. Another important MCQ point, other small openings are supraorbital foramen and infraorbital canal. They carry small neurovascular structures. So in total, we have optic canal, superior and inferior orbital fissures, supraorbital and infraorbital foramina, and nasolacrimal canal within the orbit. Now talking about the functions of the orbit. Orbit, which is the bony part, protects, supports, and maximizes the function of the eye. As you could see, this is the bony part of the orbit. It will be providing protection, support. Its foramina has blood vessels coming in, providing nourishment, taking the venous supply away, and the nerves. There's also these muscles present, extraocular muscles, which help in the function of the eye. Now, orbit provides protection and place for this whole thing to work in accordance with its functions. Further talking about the clinicals related with orbit, they are fracture of the orbit, which will look something like this. Exophthalmos, that is the forward bulge of the eyeball through the orbit, it will look like this. And there could be some infections like preseptal cellulitis and orbital cellulitis, which will appear like this. And we will talk about thyroid eye disease in detail as well. Now, talking about the fractures of the orbit, we have two fractures, the orbital rim fractures and blowout fractures. Orbital rim fractures, as the name indicate, if there is any fracture of the rim, the outer 360-degree bony structure of the orbit, it will be orbital rim fracture. Maxilla, zygomatic and frontal bones are the three bones which are forming this rim, and if any of these bone gets fractured, broken, then that fracture will be named as orbital rim fracture. Also we have is the blowout fracture. It is referred to the partial herniation of the orbital contents through its wall, which usually occurs through blunt force trauma to the eye. Now, most importantly, the medial and inferior walls, these are the weakest links of the orbit, and through these walls the contents herniates into ethmoid and maxillary sinus respectively. That is, the medial wall damage will cause herniation into the ethmoid, and inferior wall damage will cause herniation of the content into the maxillary sinus. Any fracture of the orbit which will result increase in the intraorbital pressure, raising the pressure in the orbit, causing protrusion known as exophthalmos of the eye. There may also be involvement of the surrounding structures leading to hemorrhage of the sinuses. Now, talking about the radiological image, now as you could see, this is the orbital rim, and if any of the bone gets broken, it will be an orbital rim fracture, and this is how it will look clinically. Now further we will talk about exophthalmos. It is the bulging of the eyes which causes the eyes to move out of the socket, which could be bilateral or unilateral. Bilateral proptosis, which looks like this. The most important cause is thyroid eye disease. Others are cavernous sinus thrombosis, metastatic neoblastoma, and orbital myositis. Now, unilateral proptosis can occur in case of any hemangioma, adermoid cyst, lymphangioma, or rhabdomyosarcoma. However, there is a third type of proptosis known as transient one, and it will occur in two specific cases. They include AV malformation and orbital varices. Now, further talking about exophthalmos, any inflammatory, infective, or neoplastic process that will increase the volume of the orbit will lead to forward protrusion of the eyeball, that is known as proptosis and exophthalmos. Now, talking about the signs and symptoms, there is forward protrusion of the eye. It would be painful, and that forward protrusion of the eye will cause dryness of the surface, and because of dryness on the surface, the vision will become blurry because of this dryness. Other sinus symptoms which are those specific, for example, orbital mass will be present in case of lymphoma, adermoid cyst, or any other tumor. Furthermore, pulsations can be felt on examination in case of AV fistula and meningocoele. Now, talking about the investigations which we will be performing in case of exophthalmos, blood CP and ESR. ESR is a marker of inflammation. Furthermore, we will be interested to see whether the patient is having any thyroid involvement, because thyroid eye disease is one of the most important factor for causing exophthalmos, and if it especially is present bilaterally. We will go for T3, T4 and TSH. Furthermore, we will go for ANCA. It is anti-neutrophilic cytoplasmic antibody. It will also be present in case of any inflammatory process which is present in some other system, but it is also affecting the eye, though it is a very long stretch and rarely asked, but you need to know about that. Further, we will have some imaging techniques which include X-ray to visualize the orbit and its foramina, CT scan or MRI to visualize the size and location of any pathology which is present. In case of orbital varices, If we are suspecting it, we will go for venography, and if we are suspecting AV malformation or AV fistula, then we will be going for arteriography. Now, before talking about the infections, we need to learn about the concept of orbital septum. As you could see, this is the orbital septum. It is a thin fibrous tissue which extends from the orbital periosteum down to the anterior portion of the eyelid. It is present above as well as below. Now, if you know the concept of orbital septum, it will help you to develop concept and differentiate between different types of infections which can occur in orbit. So now we will talk about the infections of the orbit. There are two types of infections, preseptal cellulitis and orbital cellulitis. Infection of the soft tissues which is anterior to the septum, including eyelids, and lead to marked edema and redness would be known as preseptal cellulitis, and any infection of the soft tissue which is posterior to the orbital septum is known as orbital cellulitis. Preseptal cellulitis is caused by a bacterial infection which may be an upper respiratory tract infection or may be present in the sinuses, or it could be post-traumatic. Again, orbital cellulitis, the most important cause or etiology, especially which could be asked in an MCQ, is the direct extension of the infection from ethmoid sinus. Furthermore, the infection can be transmitted from the lacrimal passages or the lacrimal sac. Further, eyelid infection and post-trauma can affect the orbit. One of the most important slides in this lecture, and it is about the most common organisms which are causing orbital cellulitis and preseptal cellulitis in the orbit. They include Staphylococcus aureus, Streptococcus pneumoniae, Streptococcus pyogenes, and Haemophilus influenza type B. Now, further, we will talk about the signs and symptoms which are present in these infections. In preseptal cellulitis, there will be fever and malaise, eyelid erythema and edema, and the redness of the eye. There are three primary features which differentiates orbital cellulitis from preseptal cellulitis, and they include proptosis, which is the forward bulge of the eye, which is absent in preseptal cellulitis, decreased vision, which is again absent in preseptal cellulitis, and decreased ocular movement along with pain, known as ophthalmoplegia. It is also absent in preseptal cellulitis. Furthermore, emphasizing on the concept building of this infection is the statement that if any infection is present in the anterior or front part of the eye, it will not be pushing the eyeball forward, rather backward, which is present in case of preseptal cellulitis. But if the forward bulge of eye is present, it is only because something is behind or posterior of the orbital septum and it is pushing it forward. So now I believe that you will have a much better and clear concept of why we call them differently and how to differentiate them. Now I will talk about the investigations, and they include blood CP, blood culture, X-ray paranasal sinuses to identify which of the paranasal sinuses is having the infection which is now being transmitted to the orbit, and we can also use CT brain and CT sinuses. Now the treatment is simple. As it is an infection, we will give antibiotics, for example vancomycin and other antibiotics, and NSAIDs will be given only in case of pain which is associated with orbital cellulitis. If there is unresponsiveness to the antibiotic, medical therapy, or if complications occur, then we will be going for the surgical management. Now, further talking about the complications which can occur in case of infection, they include orbital abscess, cranial nerve palsies, that is the cranial nerves can get involved, blindness because of the optic nerve involvement, meningitis if that infection spreads to the brain, and even a brain abscess can form. Lastly, we will be talking about thyroid eye disease, otherwise known as Graves' eye disease or thyroid ophthalmopathy. Graves' disease is an autoimmune inflammatory disease caused by circulating TSH receptor antibodies, which directly acts against the thyroid cells and also act on the surface of the cells which are behind the eye and cause the symptoms associated with thyroid eye disease. As you could see, this is quite a frightening picture. In this, the eyes are bulged outward, as you could see the bulging over here, and there is this upper eyelid retraction backwards and upwards, and there will be less amount of blinking. There will be other features of hyperthyroidism, which we'll be talking later on. Now, this occurs more in women, especially in their third and fourth decade of life. Now, talking about the pathophysiology. Now, the thyroid cells produces thyroid stimulating immunoglobulins, which acts on the thyrotropin receptors, which produces or activates the thyrotropin receptor, and it not only produces the symptoms associated with hyperthyroidism, but it also acts on the retroorbital fibroblast, which causes inflammatory cytokines to produce glycosaminoglycans and anti-orbital muscle antibodies. Interstitial tissue, when gets involved by the mast cells and fibroblasts, it produces glycosaminoglycans, which actually increase the water content, and the muscles of the eye, which are the obliques and the recti, they become enlarged, firm, and fibrosed. Now, the most commonly involved muscles are the inferior and medial recti. This is a very important MCQ point. Now, further talking about the clinical features. Number one, systemic features of hyperthyroidism, which we are well aware of: tachycardia, weight loss, fine tremors, and many more. But we are more focused on the symptoms and signs related to the eye, and they would be painless in case of chronic development and painful in case of active thyroid eye disease. There will be proptosis of the eyeball and mild to moderate discomfort. Now, the ocular signs include restrictive myopathy, which we already discussed in the pathophysiology, that the muscles gets inflamed and fibrosed and their movement gets limited. Then the optic nerve gets compressed, leading to decreased and blurry vision. Now, further we have bilateral exophthalmos because of lid retraction, and it leads to exposure keratitis, which is a very gross complication of thyroid eye disease. As you could see, retraction of the upper eyelid, also known as Dalrymple sign, as could be seen over here, that the eyelid is moved upward. Now, when the globe of the eye at this point will move downward, the eyelid will not follow it. There will be this lid lag known as von Graeff's sign. Then there will be infrequent blinking known as Stelvach sign, and weakness of convergence known as Mobius sign. Now, the investigations would be to identify hyperthyroidism, which includes T3, T4, and TSH levels. For eye, we have ultrasound, CT scan, and MRI. Furthermore, the diagnosis will be made on the features of hyperthyroidism and restrictive myopathy, and the specific investigations to identify hyperthyroidism. Now, lastly, we will talk about the treatment. We have to control hyperthyroidism. For that, we will be using iodine and antithyroid drugs, radioactive thyroid, and even thyroidectomy. For the control of ocular discomfort, we have artificial tears and lubricants. Now, for orbital decompression will be required when exposure keratitis or optic nerve compression has occurred, and it is done by means of systemic steroids, which include oral prednisolone and IV methylprednisolone. Orbital radiotherapy in case when systemic steroids are contraindicated, and surgical decompression when both the medical managements have failed or are contraindicated. We have two surgeries. We have darsography in case of exposure keratitis, and squint surgery for the correction of diplopia. Thank you very much for listening. If you like my lectures, kindly share them with your other medical friends so that they can benefit from these lectures as well. Thank you very much.